Well, greetings everyone, and welcome to the EKG case for the week of July 22nd, 2013. This week's case is kind of a continuation, or the final installment in the series of discussions that we've had on AV blocks, and specifically on Mobitz 2, finishing up the discussion from last week on Mobitz 2, which is on second degree AV block, which includes Mobitz 1 and Mobitz 2, which is probably the most commonly misdiagnosed of the various AV blocks, over and underdiagnosed. Anyway, here's the EKG. This was, I think, about a 45 or 50-year-old guy who presented to the emergency department complaining of some palpitations and some lightheadedness. And here's the 12-lead EKG. And you take a look at this, and the computer called it Mobitz 2, and the emergency physician called it Mobitz 2. And the intensive care physician came out and saw the patient, called it Mobitz 2. It's nighttime in this hospital. There's no in-house cardiologist, so the intensive care physician looked at this just like everyone else and said, well, there's a non-conducted beat here. So we're obviously thinking about an AV block. And so we're going to look at the PR intervals, and the PRs are staying the same everywhere. There's non-conducted, non-conducted, non-conducted. This is Mobitz 2. So they called it cardiology, and the cardiology said, all right, well, fine. If the patient's stable, I'll come in first thing in the morning. By the time the patient got up to the ICU, he had converted back to sinus rhythm anyway. So cardiology says, just take care of him, and I'll see him in the morning, and if he needs a pacemaker, we'll do it in the morning. Call me back if there's any problems overnight. Patient went through the night, no problems, did perfectly fine. Cardiology came in the next morning, and they took a look at the patient who's stable. They took a look at the 12-lead EKG, and they said, why in the world was this patient even admitted in the first place? This patient should have gone home from the emergency department. And it was a bit of a source of embarrassment for all those people who are involved. So this is not a Mobitz 2. How in the world can you say it's not Mobitz 2? All the PRs are constant, there's drop beats. All right, well, let's review what we talked about last week. Here is a classic Mobitz 1. You recall, with Mobitz 1, there's dropped beats. That's a subtle one, but there's a more obvious dropped beat. And the PRs get longer and longer, and then there's the dropped beat. Everyone knows that. But one of the things I said last week, which is important, is that before you call something Mobitz, you've got to make sure that the P to P interval stays the same. So here's our P to P interval, and if you had calipers, you'd find that this does map out perfectly fine, including across the drops. Now, I said that was really important last week, and that this week I would explain why, and here we go. Okay, so that's Mobitz 1. I'll get there. Here's Mobitz 2. I showed this to you last week. Again, why is this Mobitz 2? Well, there's dropped beats, all right? The PRs are staying constant everywhere, and again, the P to P interval stays constant all the way across. Before you call something Mobitz, you need to make sure the P to P interval stays constant. If you have calipers and map it out, you find that this stays constant, even though my drawing may not appear so. Let's look now at the case in question. Here's that 45, 50-year-old guy with the Mobitz 2. Is this a Mobitz 2? Well, there's dropped beats. Sure, we got that. The PR interval staying constant. Sure, we got that. But is the P to P interval constant? Let's take a look. There's the P to P, and we're mapping it out, and it's not. Okay? That's where the P wave should have shown up. Instead, it came early. Okay? And if we map that out at the same rate, that came early, and that came early also. What exactly is going on? What are these beats then? Well, they're early, they're atrial. So those are simply premature atrial complexes that were not conducted. Those are non-conducted premature atrial complexes. The name gives it away. Very simple name. Sometimes people call them blocked PACs or non-conducted PACs, premature atrial complexes, and very, very frequently they are misdiagnosed as Mobitz 2. And the reason people misdiagnose this as Mobitz 2 is because people forget that before you call something Mobitz 2, you've got to map this out and make sure that the P to P interval stays constant. If it doesn't, if the non-conducted P wave comes early, that's simply a non-conducted PAC. Now, what exactly is going on here? Well, in order to understand what's going on, I have a very, very simple analogy. And I mentioned this at the end of the podcast last week. I like to think of the heart as very similar to your home toilet. All right? Believe it or not, very similar There we go, to the home toilet. Now, how does your toilet work? In simplest terms, you push a lever, and that sends an impulse down to the toilet bowl to flush. It's very similar to the sinus node sending an impulse down to the ventricle to contract. So when your toilet flushes, that's actually toilet depolarization in my brain. Okay? Toilet depolarization. And the lever is kind of like your sinus node. Now, right after your toilet flushes, you get the big flush, the depolarization, it's like the ventricle contracting. Right after your toilet flushes, there's something that happens. It slowly fills back up. Let's go back to the toilet. And let me flush it again, okay? Right after the flush, the toilet's empty, by the way, so don't let your measure. Okay, so here we go. Right after the flush, you hear that sound? That's the sound of the toilet filling. What exactly is happening there when the toilet fills? I like to think of that as toilet repolarization. That's the repolarization phase of your toilet, okay? Just like in the ventricle, you need a certain amount of time for the ventricle to repolarize and be ready to go again, or be ready to flush again, or be ready to contract again, I guess I should say. Now, what exactly happens with a non-conducted PAC? What happens here is that when this impulse comes down and the toilet has not yet filled back up, the toilet's repolarization has not been completed, the ventricle has not fully repolarized, you don't get a flush, right? It's just like if you're in the bathroom and you flush that toilet. Let's do it one more time, just for fun here, okay? So we're gonna flush. I'm gonna step out of the bathroom for just a second. All right. Now here's that sound again of the toilet. Now I'm gonna try to flush again during this repolarization. I'm trying to flush. Nothing's happening. I'm not getting another flush here. But you know what happens when you try to flush again too early? Not only do you not get a flush, but you get an extra long pause before that toilet's ready to go again. You get a compensatory pause or non-compensatory. I always get those terms confused. You can just get a pause, okay? And you know that happens in the toilet. When you're in the bathroom and you're trying to get out of there quick and people are banging on the door and you flush too early before that toilet's ready to go again, now you have an extra long pause to wait. And that's exactly what's going on here. Somebody tried to flush that toilet too early before the toilet was ready to flush, and it ends up happening, what ends up happening, you get no flush, there's no QRS complex in there, and you get an extra long pause before it's ready to go again. So when you try to flush or you send a P wave down to the ventricle before it's ready, you end up not getting a conducted beat, and you end up with an extra long pause. That's all that's happening. All right, so think of your toilet, if that helps. All right. By the way, I came up with this analogy when my kids were at the potty training stage, and I've never, ever forgotten that analogy or how it's helped me avoid these non-conductive PACs. And it's important to know about this because your computer always, well, not always, but practically always misdiagnoses these as Mobitz 2 because it doesn't know about the toilet. And so that was misdiagnosed Mobitz 2. Here's another one. Now, this person has a huge first-degree AV block, so this person has other issues going on. But the computer misdiagnosed this as Mobitz 2, and, well, let's see if it is. Well, the PRs are constant. We're okay with that. But before you call it Mobitz 2, you've got to map these out. And do these map out regularly? And no, they don't. That's not a non-conducted normal beat. That's a non-conducted PAC. And this is another example where the computer miscalled it Mobitz 2. And let's map this out and see whether it really is a Mobitz. And it's not. That's where the P wave should have been. Instead of the P wave came early, it's a non-conducted PAC. That's not Mobitz 2. Now, why is it important to know the difference between non-conducted PACs and Mobitz 2? Very simple. Mobitz 2 patients oftentimes get pacers. Non-conducted PACs need nothing. It's a benign rhythm. When you see non-conducted PACs, ask the patient if they're drinking too much caffeine or taking cold medicines or check their electrolytes. Almost always, in my experience, these are patients that have mild hypokalemia or hypomagnesemia. No, not a big deal. The patient that we started out with here had a potassium of 3.3, went up to the ICU, they corrected it, and by the time the patient's potassium was corrected, he went right back to sinus rhythm. So mild electrolyte abnormalities, these patients certainly don't need pacers, and there's a good chance that a lot of these patients don't even need to be admitted in many cases, all right? And your computer doesn't know it. So if you miss this and somebody else picks it up, it's a huge source of embarrassment. If you miss it and the admitting people don't make the proper diagnosis either, it could result in unnecessary procedures like a pacer. So it's a big deal. We don't want to send home patients that are really sick, but we also don't want to admit patients that have benign conditions because it just takes up a bed and it might result in unnecessary procedures. This is a common mimic of Mobitz 2. And I'll bet you that, over the next few years, if you see 5 Mobitz 2 cases, I'll bet you 2 or 3 turn out to be non-conducted PACs. At least half the time I see, probably more than that, more than half the time I see a computer reading something Mobitz 2, it turns out to be nothing more than a non-conducted PAC, a benign nothing type of rhythm. All right, the EKG machine doesn't know this any better. And in fact, a lot of the cardiology EKG gurus will say, and the person who taught me, Edward Chung, used to always say that the most common cause of a pause on a 12-lead EKG is actually a non-conducted PAC. So these are not uncommon. The final take-home point here, before you ever diagnose somebody as having Mobitz, 1 or 2, before you ever call something Mobitz, you've got to make sure that the P to P intervals are fairly regular. If the non-conducted P wave is coming early over and over, that's not Mobitz. That's simply a non-conducted PAC. So before you ever call something Mobitz, again, make sure you're not being misled by a non-conducted PAC. All right, well, I hope that was helpful. I hope you'll always remember the toilet analogy. And again, like I said last week, if you don't like the toilet analogy, then call for a refund on your subscription price. I'll be happy to give you a full refund. All right? Until next week, take care.